This program is intended to be general in nature and should not be used as a substitute for advice from a qualified health provider.
On Health Matters Television for Life, an estimated 1 in 5 adults has a diagnosable mental disorder. Some people get help, others aren't so lucky.
We know that the jail houses so many people who are mentally ill who end up in the jail from their behavior.
In Spokane, enhanced police training seeks to change that. Learn what's being done as we set the spotlight on mental health. Right now on Health Matters.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.
And good evening. I'm your host, Teresa Lukens, and welcome to another edition of Health Matters. Tonight, we tackle the topic of mental and behavioral health, from depression to schizophrenia. We'll look at community mental health and strategies for individuals and families. And here to bring their perspective and their expertise, our panel for the evening. Dr. James Kirby is the medical director at Kootenai Health Behavioral Health. Mariah Rhodes, the Director of Transitional Services at Frontier Behavioral Health. She is a licensed mental health counselor in the state of Washington, as well as a child mental health specialist. Tamara Sheehan is the registered nurse, and she is the Director of Psychiatry at Providence Sacred Heart Medical Center. Kira Tejan is a psychiatric mental health nurse practitioner, and she works at Rockwood Behavioral Health. And finally, Alex Jackson is Chief Executive at Holy Family Hospital and Sacred Heart Medical Center. And I want to welcome you all to the program tonight. And before we do get started, I want to let you know that you will see a few phone numbers on the bottom of your screen during the show. Those numbers are to first call for help. There's a local number and a toll-free number. And if you are in immediate need of mental health assistance, we urge you to call one of those two numbers. You'll be connected with a mental health professional. Again, that's for anyone in need of help immediately or anyone with a question that they don't want answered here on the air. And a reminder, if you or someone you know is about to harm themselves, please call 911. And again, thank you all for being here. This is a very big topic. We're going to try to get through as much of it as possible. We do welcome your phone calls and emails this evening for our panel. Let's first define each of your roles as it pertains to tonight's topic. Dr. Kirby?
I'm a psychiatrist at Kootenai Medical Center in Coeur d'Alene and the medical director for psychiatry there.
Mm-hmm. And what type of patients do you work with?
I strictly work on the inpatient unit, so it's pretty much all psychiatric diagnoses and in an inpatient setting, so more acute problems.
Mm-hmm. And Mariah?
I run a couple different programs. My services are focused on transitional populations. I run a mobile crisis team that focuses on any age range, providing brief crisis intervention services and resources to people, just trying to connect them up with appropriate resources. And then I also run wraparound intensive services for children. And then I'm about ready to start running a transitional youth wraparound services for adults that are going to focus on 18 to 24-year-olds.
That's a lot of hats.
Yes.
That you're wearing. An incredibly big job. Tamara.
Well, hi. I'm in charge of operations for psychiatry department at Sacred Heart. As you said, I'm a registered nurse, so I'm in charge of the nursing pieces. We have departments within inpatient, outpatient, emergency room, and also a procedural area, and we do both adults and pediatric patients. So,
okay. And Kira?
I am a psychiatric nurse practitioner at the Rockwood Outpatient Behavioral Health, so it's all outpatient, and then we rely on all the other services for the more acute patients. I'm seeing primarily children and adolescents as well as some young adults.
Okay. And Alex, thank you for being here tonight.
Thank you. I serve as the Chief Exec of Providence Sacred Heart Medical Center and also Providence Holy Family Hospital.
All right. Well, brain and behavior disorders are fairly common in the United States. 1 in 4 adults will suffer from 1 or more mental health disorders in any given year. That's a lot of people. So again, this is a huge topic that we're tackling. Let's try to define some of the perimeters here. When we say depression to schizophrenia, there's a lot in between as well. Dr. Kirby.
Well, the depressive disorders are mood disorders, whereas schizophrenia is a lifelong condition that is primarily a psychotic disorder.
And then some of the other things that we're talking about tonight?
Anxiety disorders would actually be the most common of all of the psychiatric disorders, looking at the whole population.
Mm-hmm. And when it comes to working with youth and adolescents?
The younger children have different diagnoses. Behavioral dysregulation, ADHD is fairly common. As it starts transitioning into the teenage population, we start to see more of the traditional adult diagnoses start to emerge.
Mm-hmm. And what are you saying?
Well, we run the gamut of kind of
A
different
wide range.
diagnoses because my crisis team, we see them as young as 4 or 5, and we've seen them as old as almost 100. And so, we see a lot of psychotic disorders, a lot of depression. The kids that we see in my wraparound intensive services, a lot of depression, a lot of attachment disorders, and just really kind of I think a lot of anxiety as well, but a lot more just chronic mental illnesses that just seem to take a long time to resolve or get treatment for.
Mm-hmm. Is the problem bigger now than it was in past years? Are we seeing more?
It's hard to say that. Sometimes it feels that way. I think that it just seems that maybe because there are more resources now than there were before, that maybe the problem seems to be a little bit more prevalent. But I think that it's always been there.
Mm-hmm. And speaking of resources, Alex, talk about what we have available in Spokane and working as an administrator, working with the other health resources that we have.
Sure. So there's lots of resources in the community. I'll speak more to the services available in Providence. At Sacred Heart, we have 72 licensed behavioral health beds, both for adolescents as well as for adults. And as Tamara can talk to more of the detail, we serve people across those age ranges in the emergency department, and then for those patients needing an inpatient bed, we have services for them.
Is that comparable with the other health services in Spokane?
So we're the largest inpatient provider in the area, and we've been really proud to serve this patient population for the last 45 years. Part of our mission statement is caring for the poor and the vulnerable. And when I think about patients who struggle with these issues, I really think they're vulnerable. And our role is to make sure our arms are always open and caring for them.
Mm-hmm. And Tamara, talk more then about the inpatient services at Sacred Heart.
Well, we have the adolescent inpatient services. That is a population of patients that are 12 to 13, all the way up to 18, and that is it's really a stabilization area. It's where they come in acute crisis. We work on medication management, some behavioral work, and then we discharge them to outpatient services in Frontier Behavioral Health, often, or their own outpatient areas. While they're there, we do have we have a psychologist that assists with that care and do some psychological testing and help with behavioral plans so they'll be safe when they leave. We also have family therapists that help the entire family. And then we have the adult population, which is 18 to, I don't think we've had somebody who's 100, but I know that we can get some elderly people in there because again, it's all ages that this affects. And we have similar services. We have good partnerships within the community to help ensure that we're trying to discharge these patients with safe plans and try to keep them with their dignity when we do that as well.
Mm-hmm. Are there enough beds?
I would have to say no. I mean, I think we all know we've heard within our state, within our community that work every day with, even with Kootenai Health, we will partner with quite a bit. We know that there aren't enough adolescent or adult beds, and in some instances we don't have beds for children under 12, and so there aren't enough beds right at the moment. But that is a state and a nationwide problem, and we try to do what we can, and I think we have some brightness in the future with adding 100 beds to our community here in the next year and a half or so.
Yeah, I think one way of defining if we have enough beds is we look at the state of Washington. Washington has the second fewest inpatient mental health beds of any state in the country. And, you know, I always think about Washington as a leader, but this is a place that we don't have enough inpatient beds. And so there has been a concerted effort across the state of Washington through the Certificate of Need process to add more inpatient beds in the community. And we're really proud to collaborate with Fairfax to build a new 100-bed hospital almost adjacent to Sacred Heart. Fairfax is the state's largest provider of mental health services on the west side of the state. And so through this collaboration with Fairfax, the largest west side provider and Spokane's largest provider will bring a new 100-bed hospital to the Spokane and really the region in the spring of 2018.
And will that make a big difference then?
Yes.
Yes, with 100 extra beds. How is it comparable to when we cross over into Idaho?
Well, Kootenai Health is a regional medical center really for the northern 5 counties of Idaho. So 60 of our 296 hospital beds are dedicated to behavioral health. So we have 26 adult beds on our adult unit and 25 on our child and adolescent unit and another 15 for chemical dependency treatment.
Okay. Kara, let's get into some more of the nuances of talking about mental illness and what we're talking about and how family members can help to recognize a problem with a loved one, or how myself or anyone can recognize the problems that we're having. And some of those early warning signs, I guess, is what we're looking for.
I think the biggest key is just to not be afraid to talk about it. A big myth is that talking to somebody about depression or suicide will increase their risk, and it's not true. It's important for family members to have open dialogue. Sometimes with children and adolescents, they don't feel comfortable talking to parents. So it might be another family member, it might be a school counselor, it might be a sports coach. So I think it really does take a village as far as that goes. Just as many eyes on people as possible, asking questions, checking in. You know, how are you doing today? Or, you know, I've noticed you've been different this week.
I would imagine, especially with kids and teenagers, they might not even recognize those signs. They might not know what they're feeling. Mm-hmm. And so having a hard time even expressing them, probably.
Mm-hmm. Yeah, and sometimes the psychiatric illnesses will present differently in children too. So even for primary care physicians who have busy clinics, trying to pick up nuances are quite difficult in everything that they're trying to manage physically.
Mm-hmm. But what can a family member do then if I do recognize something in a loved one?
Well, I think that you can call. I think that we have 2 really great resources at Frontier Behavioral Health, which is our crisis response services, our first call for help hotline, as well as the team that I run as well, which is called MCAT, or Mobile Community Assertive Treatment. And you can just call. I mean, you have access to mental health professionals 24/7, and so just the ability to say, hey, this is my family member, I'm concerned about them, and this is what's going on, and just the ability to have somebody come out and outreach to their home and provide resources, provide assessment, or even just provide support to the family as far as what might be some possible interventions that could be helpful for that person.
With some mental illness, there can be a family history, and it can run in families. Is that right?
Yeah, there's definitely the 5 major psychiatric illnesses all have a genetic component. So, major depressive disorder, bipolar disorder, schizophrenia, of course, and in the anxiety disorders, panic disorder and obsessive compulsive disorder. So they all have a genetic predisposition. So it's not everyone in the family, but it's more likely in family members if one of the family members suffers from one of those conditions.
What would be a general course of treatment?
Well, going back to the earlier question, one of the challenges is to differentiate between normal and something that's actually an illness. And society's not always comfortable with that. They'd rather normalize things and say, oh, well, they're just depressed, and not think of it as an illness. And the terms we use are so general that sometimes depression for one person might be a bad day. For another person, it might be a life-threatening illness. And so that's, I think, one of the challenges that family members might have is that, when is it bad enough that we need to seek evaluation and treatment?
And it might get to a point where it's bad enough. Yeah, exactly. So with the course of treatment then, let's get back to that. We're not going to be able to tackle each one, but a general course of treatment for the more serious mental illnesses.
Well, there's psychiatric medications are very helpful, but the combination of the right medication and psychotherapy is always going to be more effective than either one alone. And so it's getting harder to find those services. There aren't enough mental health providers around, and so that's one of the challenges that we face is on our inpatient unit, we may see people there, but then when we're referring them back into the community, it's sometimes difficult to find psychiatric specialty treatment for them when they leave the hospital.
How long is a typical stay for a patient?
For our adult inpatient unit, it runs between 7 and 9 days. Adolescents could be around the same amount. It's we some of our length of stays are skewed because we have challenges getting into more long-term care. The long-term care for the adolescents, for sure, there's not as many beds in the state.
How do you make that distinction if a patient needs inpatient care or outpatient care? Where is the line?
It's basically a safety question. If someone is suicidal or if they're psychotic, meaning they've lost touch with reality and might endanger themselves or others, then that's clearly a need for inpatient treatment. Some people have comorbid medical problems that might make it more difficult to start them on medications or adjust their medications, and so sometimes that might be another reason to be hospitalized. But it's mainly for safety. Most of the treatment we can provide, we can do outpatient, but we need to do it in a safe, supportive environment for some people in order to ensure that people who are at risk for suicide don't have that opportunity.
There used to be quite a stigma attached to mental illness. Is that still the case, Kira?
I would say there definitely is. I think it ties into friends and family being able to recognize. As Dr. Kirby was saying, they might just think it's a bad day, or they might not want to talk about it. They might not want to admit that somebody in their family or loved one is struggling. There's definitely lots of efforts locally and nationwide to help fight against that stigma, but I think it's fairly deeply ingrained.
Go ahead, please.
It may sound cliche, but I'm just about every day say that depression, for example, is not a character flaw, it's a chemical flaw in the brain, or say that it's an illness, not a weakness, because those are common myths and misconceptions, I think, in society, that somehow a person is weak or defective in some way if they suffer from those things, but really they're very common and anyone can suffer from them.
Well, and we tend to separate it. We have mental illness over here and then all other medical conditions here. Well, the brain is a part of the body. This is a health condition. This is like cancer or any other disease. So once we recognize that, it becomes a little more clearly defined, I think, for people and able to accept that. You just need treatment. Is that the case? For families especially?
Yeah, I think that it can be difficult, but I think that the more awareness that we have towards being able to access mental health treatment, and that it's not just the old traditional idea of mental health treatment where if somebody has a mental illness they get locked up for the rest of their life, that there really are other things that you can do to assist people, and that it really is okay. I think that it's really just about education too. It's really providing a lot of education to the family and to the client themselves about, you can live with a mental illness and still be, a happy, healthy, functioning member of society.
Let's take our first phone call this evening from Deanne in Spokane. Good evening.
Good evening.
Thank you for calling.
My question is related to access to services here in the Spokane area. My history is I was a traveling nurse, an ER nurse, and also a forensic nurse, helping victims of domestic violence and sexual assault. Recently, I'm now disabled, and recently I found myself in need of some counseling related to a lack of social support around me. And I called at least 20 different places here in the Spokane area because I'm disabled and I have Medicare. I was unable to find assistance related to counseling services. There are lots and lots of people on Medicare that have different crises in their life and have need of counseling services. And I'm just wondering if we have any push towards providing that for our community.
It's a very good question. Who would like to take that? Tamara?
Well, I think that she's right on point. It is very challenging. That's one of the primary gaps we have in our community, as Dr. Kirby was talking about the lack of providers, even when he's trying to discharge his patients. For patients that, oddly enough, have insurance and are on Medicare, we have a much bigger challenge to find care for them in a timely manner. Sometimes it's 90 days or more before you can get somebody in to see an outpatient provider that can manage their medications and help them stabilize in the community. So, it's one of those things where we don't really have an answer right now. We know it's a gap. I know that we've had conversations with our partnership with Fairfax and even within Providence Health and Services to try to help try to make that gap less.
What would be your advice to her?
Boy, I think utilizing the first call for help when she gets to a point that she feels like she needs somebody to talk to, find some supportive services, go ahead and try to continue to try to get yourself on a list to see a provider. But obviously, if she's immediately feeling homicidal, suicidal, any of those things that Dr. Kirby spoke about, to call 911 or to bring herself into the emergency room. And that actually, unfortunately, is what our access to service right now would be for somebody like Deanna.
Okay. These are conversations that need to be had.
Yes, certainly. And one of our commitments right now that doesn't help us today or tomorrow, but will help us in the seasons and years ahead is we've made a commitment and we've started a psych residency program to train the next generation of physicians. As we look nationally, there's greater demand than there is supply of psychiatrists. And so part of our commitment to the community is to grow a residency program so we can train the next generation of physicians. We know if we train a physician in Spokane, the chance of her or him staying in Spokane is great. So I know this doesn't help her today. I apologize for that. But we are aware of this, and we're working with community partners, too, to try to address this gap that we're seeing today.
Okay. Elizabeth calling from Spokane. Good evening.
Good evening. My question is for your panel, and I want to thank them for their service to mental health in our community. My question is, when a patient is in a mental health crisis and they go to the emergency room department, I'm understanding there's often a 4 to 5 day wait in an emergency room bed, and I'm wondering how their mental health care is handled during an ER visit while they're having that 4 to 5 stay in an ER bed. I'll take your answer offline.
Okay, thank you very much. The assessment process and the process that someone has to go through when they go into the emergency room.
So right now, if they come to Sacred Heart Medical Center, it is different in other community hospitals. But they come into the emergency room presenting with a mental illness concern or brought in through the ambulance system or the police system. We do have a team of mental health counselors. They're on 24 hours a day and multiple individuals. And they are assessed for their safety level. A lot of people come into crisis and are able to have a good safety plan and leave the hospital fairly quickly. Other people are not. And so we do have times where we have periods where there's wait times, depending on the situation, depending on our community resources. I mean, often we can call an MCAT team, call Frontier Behavioral Health if they're already enrolled in services. We can start that process fairly quickly, and we can help get people assessed by a psychiatrist as well within the emergency room if that's needed to help get the medication management until we can stabilize them. And there are, I think, And Spokane is no different than Washington State or the national problem with we do have patients who are in need of mental health services waiting in our emergency rooms, both in pediatric and adults. Some of the things that we use those mental health counselors to help try to provide the best care we can, and we have supportive services. I know in the pediatrics area we have child life specialists, and we have support systems that we're putting into place with resources we have to try to provide that. I think some of the when people come in, and I keep saying stabilize, because in the hospital you're in a crisis, and we're just trying to figure out what is a safe discharge plan, and often that's just providing medication management, get people stabilized in that way, and then provide their mental health services for counseling and so forth outside of the hospital. It's a complex problem because there's people wanting help, and it takes a long time sometimes to get that help.
Talk about that team approach that Tamara mentioned, the MCAT team.
Yeah, MCAT actually came about as a result of the psychiatric bed shortage, and the reason for that being is that there are plenty of people that need psychiatric services, but there aren't enough psychiatric beds to treat them in. And so the goal is that if we could get a team involved, a multidisciplinary team, which is what MCAT is. We have mental health professionals, chemical dependency professionals. We have a nurse on our team. We also have peer support of people that have mental illnesses that are currently in recovery, and they're also a part of our team. And really the goal is to be able to try to connect up with the community providers where these people are making contact with, and see if we can't do some early intervention prior to them getting to the point of needing inpatient psychiatric hospitalization. And so we really reach out to our community partners. So we get a lot of our referrals from emergency rooms, and a lot of our referrals from law enforcement and the county jail, and as the community learns more and more about us, different community providers. And really the goal is to outreach to these people that need assistance homes, provide them the resources in the community, really do a little bit of hand-holding, especially for those that are having difficulty navigating the system of care. Because sometimes that's the biggest barrier to receiving mental health treatment is how do I get into it, or how do I apply for Medicaid, how do I apply for insurance, or what are the systems that I need to navigate through to get myself into chemical dependency treatment. And so that's really where MCAT is filling the gap that was there before. It's really just making that connection.
I'm glad you brought up law enforcement, because I do want to talk a little bit more about that, because when a mental health disorder hits a crisis point or is left unchecked, it's quite often police that get called. Calls range from someone wandering the streets to an attempted suicide. In Spokane, officers do get special training to assist them. And tonight we have a rare look into their world thanks to body camera footage provided to KSPS by the Spokane Police Department.
It's hard to say how many calls the Spokane Police Department gets that are mental health related. They come in as welfare checks or reports of someone acting bizarre. But safe to say, officers see it all of the time.
Certainly over the course of a week, they're going to see many.
Sergeant Dan Waters oversees the department's CIT program.
CIT stands for Crisis Intervention Team Training. It is a 40-hour block of instruction that officers learn about aspects of people who might be in behavioral health crisis or crisis induced by perhaps drugs.
It's mandatory, with a 4-hour refresher course every 2 years.
Kind of gives officers some ideas about mental illness and what it looks like, and so they can make some determinations on that person, on how to help that person.
It gives them tools, Sergeant Waters says, that they don't get in the academy. It also helps the officer avoid sending someone to jail.
It's best for us to try and figure out how to help them in our community so that they avoid future crisis, so that's not this kind of revolving door for them and the system.
The CIT model is compassion-based without compromising safety.
Keep walking, you're doing good.
In this footage, officers encounter a suicidal man. It's hard to see, but the man is carrying a gun. He poses a danger to himself and others and is quickly handcuffed.
We just have to make sure that you're safe and that we are safe, okay? I appreciate your cooperation.
He is checked for other weapons.
Is there anything in your pocket?
No, nothing at all.
The man is walked to the curb and sits down. Next, the officer begins to ask him questions.
What else is going on?
It doesn't take long before the officer learns that the man hears voices in his head.
And what are the voices telling you to do?
They're not telling me to do anything. I'm hearing them talking about me.
Then the officer asks why he has a gun.
I wanted an honorable man to end this for me.
The officer learns the man wanted police to shoot him, what's called suicide by cop. He'd put on a suit and a tie and is carrying a Bible.
I have such a hard time thinking that someone as good as you would want something like that, man.
The man tells the officer about the medications he's taking, and it's clear the man is suffering from a mental disorder.
What are these all for?
Mostly for being schizophrenic and depressed.
Medics arrive to make sure the man is okay.
Well, they're going to check, okay? Is that all right?
Yeah.
They just check your blood pressure, your pulse, all that stuff, okay?
What started with police commands and handcuffs quickly turns from combative to calm.
That's one of our enhanced CIT officers. Once the situation is safe and under control, then we switch to a different mode.
A situation that could have been deadly ends peacefully.
We want absolutely everybody to be safe. The person involved, the officers, any bystanders.
In the end, the man is not arrested, but is referred for help.
And that is a rare glimpse at something we don't often get to see. Pulling back the curtain a little bit on what police officers have to deal with every single day. Talk about how they did. They seem to handle the situation quite nicely.
We really have some impressive police officers here in Spokane. The Spokane Police Department is partnered with Frontier Behavioral Health, and they provide Frontier Behavioral Health provides crisis intervention week-long training to law enforcement officers here within the city, and also I believe the county as well. And really what it does is it's training them about what does mental health look like and how do you intervene when they're in a crisis, and they really do a nice job of de-escalating situations and really just trying to get an assessment of how can we handle this in the least restrictive way possible.
And they have to make split-second decisions.
Absolutely.
This man had a gun on him.
Absolutely.
And so when they're training, I mean, they have to train to be a police officer, and they have to train to be a mental health professional. That's difficult.
Yeah, absolutely. I think that, they're often asked to be kind of a jack of all trades with that kind of thing. And they really, and I speaking about law enforcement policies and procedures, obviously that's not my role here, but just my experience working with law enforcement in the field, they really try to do what is best for that person at that moment in time, and realizing that that person is at a heightened level of crisis. And they work really well with our mental health professionals to really make sure that the person is receiving the type of care that they need.
That can also take a toll on them.
Absolutely.
And so I imagine they have follow-up trainings and pieces in place that actually help them then deal with the stresses that they have on the job.
Yeah, it's my understanding that that's true. I'm not 100% sure what their internal policies are, but yes.
How much training would they have? I know that's not your area of expertise, but how long would they be in training before we see them in a situation like that?
Well, I would suppose that it would vary. I know that they try to get new officers through crisis intervention training pretty quickly, but it's really hard to say. I would suppose that
hours worth,
possibly. But
what would be the next piece beyond what we saw there? What would happen next for that particular patient in a scenario like that?
In our community, our law enforcement also have CIT training, and it's made a big difference. They would most likely be brought to the emergency department, and they would have an emergency evaluation there, screening, laboratory testing, checking to make sure if drugs or alcohol are involved, and screening for any other medical problems that might be contributing to their mental state. And if in a case like this, there's clearly ongoing risk, and the patient would need stabilization and would probably then be admitted to the psychiatric unit at the facility after being evaluated, triaged in the emergency department.
Alex, quite often we have a large homeless population, and this problem is prevalent with our homeless population as well. How do you network with the nonprofit organizations that help the homeless to deal with mental illnesses?
So I'm not aware of all the networking we do and don't. I do know that about 20 to 25% of the adult homeless in Spokane do suffer mental health conditions. So I think it's a real issue, and we see some of those folks with their mental health condition in our hospitals as well.
Mm-hmm. Tamara, will you hear from places like House of Charity then when they need assistance?
Well, not necessarily when they need assistance. We do work with them to, if we have an individual that we've cared for and that is their lifestyle where they live homeless, we will, House of Charities, the mission, we will discharge them to that location under their care. So there is work done there. I know that MCAT also does some of that work as well. But they would, if they had an immediate need, they would probably call the police or an ambulance to bring the person to be triaged, as Dr. Kirby had spoke about.
Okay. We have Jan calling from Spokane. Hi, Jan.
Hi there.
Do you have a question?
I do. I am a hoarder, and I'm wondering if that is a mental illness or if it's just something that I learned to do because my mother was a hoarder, and I don't need things, but I see things alongside the road or the sidewalk, and I just think that somebody threw away something good, or stop and pick it up. So I'm wondering, do I have a mental problem? Mental illness?
Kira?
It's difficult to say, obviously just based off of a phone call, but I think in general the assessment needs to be about the functionality of how anybody's behaviors, whether it's picking things up off the side of the road or sleeping too much, sleeping not enough, any behaviors, how much it really becomes an impairment to their lifestyle overall. I think a lot of mental health behaviors are also learned, as she mentioned. It's something we pick up from our parents, a behavior that may have been completely normal in our house growing up. So it's not always easy to say cut and dried, is this a mental illness? Is this a habit? Is it both?
If it's affecting her life in a way that it takes her away from relationships or things like that, is that a key sign?
That's usually when we like to intervene with treatment, is when those quirks or behaviors or whatever they are really cross the line into interfering with daily activities, with relationships, ability to hold work, or a deterioration from what somebody previously used to be able to do.
Mm-hmm. What would you suggest she do if she's curious about this? She's wondering if she has a problem.
Yeah, I think definitely trying to access outpatient services. It sounds that she's in a situation that's not acute, not acutely danger to herself or others. It may be difficult, as we've talked about, to find those services in Spokane, and I wish her the best of luck with that because I know it's very difficult. But I think in her situation, maybe accessing a primary care provider that can help refer her, that usually works well in the outpatient system if they can at least get a primary care doctor to help them with those referrals. Although, as someone else mentioned earlier, often it's a lot of legwork for the individual to try and find someone.
But it's a good starting point.
Mm-hmm.
Okay.
Yeah.
I would just comment also that hearing what she said about the family, there is a chance some hoarding behavior is due to obsessive compulsive disorder. And it's a very treatable illness, both with medications and specific types of psychotherapy. And it's as likely that she acquired that genetically from her mother, if she suffers from OCD, as actually more likely than learning it from her mother. Many children who have a parent with OCD are often going the opposite direction because they've had enough of that growing up. So chances are, if she has OCD, that it would be a genetic link, not a learned behavior.
Mm-hmm. Okay. Jim in Spokane. Good evening, Jim.
Hi. How are y'all doing?
Very well, thank you.
Oh, great. I have a question. There's a young man that has lived with me for about a year and a half now. He's a family friend. I met him when he was like 12 years old. He's 23 now. He developed schizophrenia. He gets a shot. I'm sure y'all probably know what that is, once a month, and that helps him out a lot. He also gets 2 or 3 medications that he's supposed to take, but he won't take them. And they turn him into a zombie. And he has started taking this stuff that he heard about on the internet. It's called kratom. I don't know if y'all have heard of it, but it's a drug that's legal. It's a plant, and people take it to help them recover from opioid addictions and things like that. Well, he started taking that, and his mind has absolutely cleared up. It's miraculous. Do you know anything about kratom and what it does to a person? It's just unbelievable. This boy's mind has come back.
Well, thank you, Jim. Thank you for your call.
That would be highly unusual. Kratom is becoming a substance that's abused because it is similar to opiates in some ways. And working in the hospital, we tend to see more of the problems that occur when somebody uses substances like that, because it definitely can be a substance of abuse. As far as I know, it's not illegal yet, but I think it will be.
Is it possible that this young man could have been misdiagnosed in some way, or?
Well, it's possible. Some patients who are diagnosed with schizophrenia might actually suffer from a related condition, such as schizoaffective disorder. And that could be a disorder that could actually cycle. It could come and go over time. And so there's a chance that it could be coincidence as well, that the condition is cycled and that he may indeed go back into a cycle of the illness again.
Okay. Well, staying on that topic, we have an email that has come in that says, how does self-medicating with substances impact or mask mental health symptoms? And that's along the same lines.
Yes, it is. And even the term self-medicating is being used probably too liberally now. But people many times don't have access to appropriate diagnosis and treatment, and do sometimes turn to alcohol or other substances of abuse, just trying to get some relief from their symptoms. Unfortunately, most of those things make it worse, not better, and sometimes become an independent problem that even compounds their psychiatric problems. So we are seeing co-occurring or comorbid substance abuse and psychiatric illnesses more and more.
Mm-hmm. How important is it to not only treat some of the more severe conditions with prescription drugs and counseling and having that team approach? How critical is that to making sure that the person stays well?
I think it's incredibly critical. Yes, some of the medicines that we give, as going to the masking and self-medicating, some of the medications we use do have side effects that are unpleasant. And as a provider, I try and work with my patients to minimize that as much as possible. And that's where the medications and the psychotherapy work really well together, is you can have some of each, and some support from the therapy, some support from the medications. I do believe that both together are very important and very crucial. Different therapies, different psychotherapies and different medication therapies are best in various combinations for different disorders. But I think that's the best for long-term stability, is that combination.
This can be rough on families, and so quite often they'll need therapy as well to just help deal with it, and you provide those services as well.
Yeah, we do provide support to the families that are really struggling with what's going on with family members. I think there are also a lot of really great resources here in the community as well. So NAMI, or the National Alliance for the Mentally Ill, they have support groups for family and close people for people with mental illness to really provide them education and support. And I think that it really just is a community effort. It's not just treating the client, it's treating the whole the whole system
and creating a better understanding and helping them understand what's going on.
Yeah, absolutely. I think mental health really is focusing a lot more on not just mental health being the only answer, mental health treatment being the only answer, but how do we provide natural supports to the person to find out who are their natural supports and how can we provide them education and assistance to really help treat that, to help, provide assistance for that person for, so that they're not in mental health treatment for the rest of their lives.
Okay. We have another email, this one from Theo from Calgary. Does seasonal affective disorder affect women more than men? My wife gets really down in the winter, but it doesn't seem to bother me so much. What can I do to help her? Seasonal affective disorder is what we call getting the blues in the winter, I guess, or in the darker months.
It's a type of depression. It's a subtype of depression. Some people with depressive illnesses will get worse during the winter, but don't just suffer from seasonal affective disorder. Some people, it's truly just a seasonal phenomenon. Depressive disorders are more common in women than in men, probably 2 to 3 times more common, so it wouldn't be unusual to see that situation. Light therapy can be very effective. It's not just any light, but there are specific types of lights that are the correct wavelength and full spectrum lights that can really provide some relief from seasonal affective disorder. So, and they've been getting more and more reasonable too. So that would be the place to start. Medications can play a role, but I would start with light therapy first.
So he's not wrong in thinking that maybe it affects his wife more than him?
No, that's very possible. Some people are not affected at all, but it's a very real phenomenon, and we're in the right
headed
latitude.
Into those months, yeah.
And in the latitude that it affects us more too.
What are we doing right, Alex, when it comes to mental health, especially in the inland Northwest?
So, I think we're talking more about it. And I think, I think the stigma was much more present many years ago, and I think we're talking more about it. I think we're more aware of resources in the community. Within Providence, we're talking more to people, other partners in the community. We're listening to them as well. And then I'm really excited that we're investing in our future in terms of training the next generation of doctors and really hoping and retaining them to stay within the Spokane area. And then 2, I'm excited about investing in more inpatient beds too, because clearly through the questions today and through the conversation, we do need more resources. We need more inpatient resources, but we also need access to outpatient physicians and providers and comprehensive services in Spokane, in Coeur d'Alene. And the other thing I remind myself about is that while there is some services in Spokane, access to mental health services in the rural areas is even more challenging as well. And so I think we do have some things going. I'm excited about what the future holds because of the conversations that are happening in the last few months and years.
Are we failing any certain population, Tamara?
Well, I think as we've been talking with the phone calls, I mean, obviously we have challenges from the ages of 4 all the way up to the elderly patients who don't necessarily have a behavioral health or mental health illness, but have dementia or Alzheimer's. I think that there's an opportunity in almost every age group and specialty, not only mental health but in autism and all the different diagnoses, the outliers of people who aren't considered mental health, but they don't have anywhere to go. There's lots of room for improvement, so that's what's good, and that's why this group is able to stand back at the green room and talk to each other about all the great things that we're doing as a community. And I think, to tag on to Alex, I think what we're doing right is we do work very well as a community with the law enforcement, with each other, and we even have a really good relationship with Kootenai Medical Center as well. I think we really band together. So we're doing that right, and we all recognize there's a lot of areas of improvement, and and we're starting with the inpatient beds and the opportunities for outpatient services to grow.
Are we approaching this, again, going back to the fact that we are talking about diseases of the mind, mental illness? Are we approaching it the way we should be? Should we not be doing well checks on children just like we do physical well checks with mental health well checks?
There are places that do so for both children all the way up through adults. I've spoken with people from areas outside the Northwest that said, oh, yeah, whenever I went to see my doctor, I met with a social worker first, and they asked me questions about my eating and my sleeping, and I thought that was normal. And then I moved here, and we don't do that here. We don't have enough providers to care for those that we already have, and so I understand that it would be very difficult to expand and start doing those things. But I do think catching those things early and the early intervention is very important.
Mm-hmm.
Really, primary care providers provide more psychiatric care than psychiatrists do because there aren't enough of us. Mm-hmm. And so I'm very grateful that most primary care doctors do really a good job, and more are starting to screen for depression, for anxiety disorders, and have some tools that they routinely use in their clinics, questionnaires and things, to try to sort that out and provide those services when they're needed.
Mm-hmm. So it's never too young to start with the process.
No, and especially if there's a family history, once again. The brain is the most complex organ of the body, so it only stands to reason that some things can go wrong, and it doesn't take much.
Mm-hmm. We're going to try and get in another phone call. Kathy from Spokane. Good evening, Kathy.
Hi, thank you. My daughter did research on nutritional supplements and how they help get our brain chemistry back to functioning properly. Her brother and my adult son, we nearly lost him more than once, but he was greatly helped by how the supplements helped remove the toxins from his brain and help get it back. I'm wondering if you're exploring things like high-dose vitamin C, niacin, B-complex, a good multivitamin mineral, and sleep, and good meals, and theanine serene, which has GABA. Any exploring on nutritional therapy for brain chemistry?
All right, very good. Thank you, Kathy.
Obviously, good nutrition and good sleep hygiene and all of those things are important for any medical problem. I mean, if we're not taking care of our brains and our body, we're more likely to be ill, and it's going to be harder to be treated and get better. A good rule of thumb is if it doesn't cause it, it's probably not going to cure it. And so just giving somebody extra of something that they might otherwise get in their diet it actually is not very often going to be successful in treating them. There may be people with vitamin or mineral deficiencies that might manifest themselves with psychiatric problems, and of course in that case a mineral or vitamin supplement could be helpful, but there really isn't much scientific evidence for people at large, the larger groups. You might find a case now and then that's benefited, but we really have to approach treatment more scientifically and what helps most people as opposed to what might help one person.
Mm-hmm. And of course, taking high doses of any kind of vitamin or supplement is something you probably want to talk to your doctor about first in any medical situation.
Definitely, because once again, if it's powerful enough to treat, it's powerful enough to have side effects and other problems.
Okay. Brittany calling from Lewiston. Hi, Brittany.
Hi.
You have a question?
Yes. So my mother, she is about 65, and she, about 6 months ago, had a psychotic breakdown, and she was diagnosed with schizophreniform illness or disorder or whatever it's called, and hasn't been the same mentally ever since or before even. And my first question is, since she's she's 65 and she's never shown signs of that before, is that common for her to be diagnosed at such a age like that? Even though, my brother does have schizophrenia, but I don't know if that's common. And my second question is, since our family is kind of coming to terms with how she's acting differently and being very obsessive about religious stuff. You know, sometimes I wonder when she asks me to, like, you know, confess my sins multiple times a day, if she actually understands that she's doing it, because I'll find myself getting upset. And does it make sense to, I mean, is it even any use if she doesn't understand?
Okay. Brittany, thank you so much. We want to make sure we get an answer for you because we are running short on time. Can you address that?
Yes, you're
Later
right.
in life?
It would be unusual for schizophrenia to come on in that age. Most commonly, it's going to come on more around in the early 20s would be more common. There are other psychotic disorders that can occur later in life. It's very important for somebody who has a new onset of a psychotic illness at that age to really have a thorough medical workup, including an MRI of their brain and other screening studies, because once again, medical problems can manifest themselves as psychiatric illnesses, and especially in that age group, that would be extremely important to rule out other possibilities that might be creating or contributing to the problem.
And then she sounds like she's getting frustrated with her mother's behavior, and so it just sounds like they need to seek some more medical help.
Definitely, because they, partly for the evaluation and treatment, but also helping the family understand what's illness and what's the best way to deal with that that's not going to aggravate things and make things worse and destroy the family relationships in the process.
Well, we have barely scratched the surface, but I'm afraid that we have run short on time. That's going to do it for this edition of Health Matters. Our thanks to everyone who was able to call in and email questions. And we hope that you will join us on December 15th when our topic will be pain management. You're going to hear from a woman who suffers from chronic pain after she's had several hip surgeries. She now uses a pain patch to bring her relief. And again, that is our topic coming up in December right here on KSPS Health Matters. Until then, I want to thank you all for watching. I'm Teresa Lukens. Good night.
Health Matters is made possible by our viewers, the friends of KSPS, and by Providence Healthcare.
My name is Beth Perez, and I am a registered nurse, and I work at Holy Family Hospital on the labor and delivery unit. I'm about to have my second child, and I chose Providence because I love and trust the people that I work with, and why wouldn't I seek care from people that I love and trust?
I'm Dr. Andrew Boulay, and when my wife had a cardiac arrest, I chose Providence because I knew that everything we needed for her complex care was available, from the emergency room to radiology to the nursing staff to the specialists we needed for her care.